You haven't gone in 4 days, maybe 5. You've lost count, actually. There's a pressure deep in your lower abdomen that hasn't shifted. A fullness that doesn't go away after meals, doesn't ease when you lie down. You've taken a laxative, maybe 2, and nothing has happened. Or something happened, but not the kind of relief you needed. Just some liquid passing around a blockage that's still very much there. You tell yourself it'll resolve. It usually does, eventually. But here's what I want you to understand before we go any further. And I say this not to frighten you, but because I've watched too many people wait too long. When stool becomes lodged in the rectum and stays there, the body begins managing around it in ways that can mask what's actually happening. And the longer it stays, the more those compensations look like something other than what they are. People come in confused, sometimes agitated, sometimes with what looks like diarrhea. And the last thing they or their family suspects is that the underlying cause is a hardened mass of stool that hasn't moved in over a week. This is called fecal impaction, and it is one of the most underrecognized urgent conditions in people over 60. Not because it's rare, it's surprisingly common, but because the signals it sends are so easy to misread. Stay with me, because what I'm going to share in the next several minutes could genuinely matter for you or someone you love. Let me start with the physiology, because once you understand what's happening inside the body, the warning signs I'm going to describe will make immediate sense. The rectum is the final several inches of the large intestine, the staging area where stool waits before elimination. It's designed to hold material temporarily, to signal when the body is ready to evacuate, and to release on demand through a coordinated muscular process that most people never think about consciously. When stool sits in the rectum too long, water continues to be absorbed from it. What started as soft material becomes progressively firmer. Given enough time and enough fluid absorption, it can become almost rock hard. A dense mass that the rectal muscles, which were designed to move soft, formed stool, simply cannot generate enough force to expel. Think of trying to push a boulder through a garden hose. The mechanism is intact, the pressure is being applied, but the material has become incompatible with the process. And here's what makes this genuinely dangerous. Not just uncomfortable. That impacted mass creates pressure on surrounding structures. The bladder, the nearby nerves, the blood vessels supplying the area, and in trying to work around the blockage, the body can generate a series of secondary symptoms that seem completely unrelated to the colon. That's where things get complicated, and that's what we need to talk about carefully. There's a symptom that I want to address first because it is the most counterintuitive thing about fecal impaction and the one most likely to send people in entirely the wrong direction. Liquid leakage. When stool is severely impacted in the rectum, liquid stool from higher up in the colon can seep around the hardened mass and emerge as what looks, unmistakably, like diarrhea. Watery, loose, uncontrolled, and so the person, or their caregiver, or their doctor, concludes they have diarrhea. Antidiarrheal medication is given. The problem gets worse, not better. I've seen this pattern more times than I care to count. A patient treated for diarrhea for several days, becoming increasingly unwell, increasingly confused, until someone finally asks the right question and does a proper examination. And the diarrhea, it turns out, was never diarrhea at all. It was the body's only available exit route past a blockage that had been building for days. If you or someone you care for experiences what appears to be diarrhea alongside significant abdominal fullness, any difficulty urinating, or unusual confusion or agitation, please do not automatically reach for the anti-diarrheal. That is a situation that needs to be evaluated, not suppressed. Now, let me talk about who is most vulnerable to this condition, because the risk factors are specific and knowable, and knowing them changes how alert you should be. Reduced mobility is the single most consistent risk factor. The colon is a muscular organ, and it moves material through it partly through the body's own movement. Walking, bending, twisting, These actions stimulate the colon mechanically in ways that sitting still simply does not. People who have become significantly less mobile due to illness, surgery, injury, or general physical decline lose this mechanical stimulation, and the colon slows. Medications are the second major driver, and the list is long. Opioid pain medications are the most powerful suppressors of bowel motility that exist. They bind to receptors in the gut wall and effectively put the colon's muscle activity on pause. If you or someone you know starts any opioid medication, after surgery for pain management in any context, the bowel regimen to go alongside it should be started on the same day, not when constipation appears. That's a management failure that leads directly to impaction. But opioids are not alone. Calcium channel blockers for blood pressure slow gut motility. Anticholinergic medications, the antihistamines, the bladder medications, many antidepressants, reduce the nerve signaling that drives colonic movement. Iron supplements cause constipation in a significant percentage of people who take them. Even calcium supplements taken in higher doses can significantly slow the bowel. Dehydration is the third factor, and it interacts powerfully with everything else. Without adequate fluid intake, the colon extracts more water from passing stool to compensate for the body's overall fluid deficit.
The result is progressively harder stool that is increasingly difficult to move, even in a colon that's functioning normally. And diet, specifically the shift toward lower fiber intake that happens in many people after 60, often because of changes in appetite, dental issues, or simply reduced interest in cooking, removes the bulk that stool needs to maintain softness and promote regular movement. Here's where I want to pause and describe something I see in clinical practice that genuinely concerns me: the normalization of infrequent bowel movements. I cannot count the number of patients who have told me, when I ask about their bowel habits, that they only go every 3 or 4 days, and that this is normal for them, and has been for years. And I ask how long. Was it always like this? And often they'll say, no, not really. It changed gradually. At some point, going every day became every other day, and then every 2 days. And it just crept further and further until a week without a bowel movement didn't feel like an emergency anymore. The body adapts. The rectal sensory threshold changes. What used to feel urgently uncomfortable becomes tolerable. And that adaptation is not protective. It is the setup for impaction. A healthy bowel movement frequency ranges from 3 times a day to 3 times a week. Most people function optimally toward the more frequent end of that range. If you are consistently going less than 3 times per week, that is not something to accept as personal baseline. It is something to address, with your doctor's guidance, before it progresses. And the thing that happens next, the thing that makes this so clinically serious, is that the rectal muscles themselves begin to lose their tone. Use them or lose them, in a very real physiological sense. Chronic constipation doesn't just cause impaction. Over time, it contributes to pelvic floor dysfunction that makes the problem increasingly difficult to reverse. I want to spend a moment on the neurological symptoms of fecal impaction, because they are probably the least known and the most alarming when they occur. Severe rectal impaction can trigger what's called a vasovagal response, an activation of the vagus nerve that drops blood pressure and heart rate sharply. People feel suddenly faint, profoundly lightheaded, sometimes cold and sweaty, occasionally losing consciousness briefly. In older adults, particularly those with cardiovascular conditions, this response can be clinically significant. There's also the direct pressure effect on pelvic nerves. Impaction that is large enough to create sustained pressure in the pelvic cavity can cause referred pain to the lower back, the hips, and occasionally the legs, which gets attributed to arthritis, sciatica, or any number of other things. It can cause bladder dysfunction because the pressure on the bladder and its nerve supply interferes with normal urination. Urinary retention, increased urgency, Even urinary tract infections can follow from an impaction that nobody has yet identified. And then there's the cognitive piece, which is the most striking of all. In older adults, particularly those in their 70s and 80s, severe fecal impaction can produce acute confusion, disorientation, agitation. What looks, to family members or even to medical staff, like a sudden onset of dementia or a psychiatric episode. I have seen this more than once. A family brings in a parent who has become acutely confused over the past 48 hours, seemingly out of nowhere. The evaluation is extensive. The workup returns largely normal. And then a physical examination reveals a rectum packed with hardened stool that has been there for a week and a half, pressing on nerves, creating systemic discomfort the patient couldn't articulate, driving an inflammatory and physiological response that expressed itself through the brain. The confusion resolved within 24 hours of treatment. When an older adult becomes acutely confused or agitated without an obvious cause, bowel status should be among the first things evaluated. It often isn't. And that gap costs people time and distress and unnecessary workup. Let me now talk about what to do, both in terms of immediate management and long-term prevention, because I want this conversation to lead somewhere useful. If you suspect an impaction is present, significant abdominal pressure or fullness that has persisted for more than 3 to 4 days, no meaningful bowel movement despite laxative use, any of the secondary symptoms I've described, this needs medical evaluation. Not tomorrow. Not next week. Fecal impaction that has progressed to a point where the standard laxative approach is not working often requires manual disimpaction, which is a medical procedure. Continuing to take laxatives in the hope that the problem will resolve on its own can, in advanced cases, worsen the situation by stimulating the bowel above a blockage that cannot pass. Call your doctor. Tell them specifically, I haven't had a proper bowel movement in more than 3 days. I have significant abdominal pressure, and standard laxatives haven't worked. Those 3 things together should prompt an evaluation, rather than a phone recommendation to take more stool softener. For ongoing prevention, the principles are consistent and evidence-based. Fiber intake needs to be adequate, and for many people over 60, it is not. The target is roughly 25 to 30 grams per day. Most Americans consume about 15. That gap is filled by vegetables, legumes, whole fruits rather than juice, nuts, seeds, and whole grains. Not supplements exclusively. Real food fiber, which also comes with water content and other compounds that support gut function. If adding fiber more rapidly causes gas or bloating, add it gradually over several weeks. The gut microbiome adjusts, and the discomfort resolves. Hydration is non-negotiable for bowel function. 6 to 8 glasses of water daily is the standard guidance, and it directly affects stool consistency. One practical approach, a glass of warm water first thing in the morning before coffee or food, stimulates the gastrocolic reflex that initiates bowel activity after a night of fasting. Many people find this alone produces more consistent morning bowel movements. Movement. Even modest physical activity, a 15-minute walk after a meal, stimulates intestinal motility in ways that no supplement can fully replicate. For people with significant mobility limitations, chair-based exercises and gentle abdominal massage in a clockwise direction can provide some of the same mechanical stimulation. And if you take any of the medications I mentioned, opioids, calcium channel blockers, anticholinergics, iron supplements, have an explicit conversation with your doctor about a bowel management protocol. This is not optional information. It is a clinical necessity, and it should be part of any medication conversation where bowel motility is at risk. One more thing I want to say, and it's the part of this conversation that matters most to me. People don't talk about this. Not to their families. often not even to their doctors, who they see briefly and feel they should spend the time on more important symptoms. Bowel function is private. Discussing it feels embarrassing. And so it gets managed quietly, at home, with whatever the pharmacy shelf offers, until it becomes something that can no longer be managed quietly. That silence costs people. It costs them comfort. It costs them time. Occasionally, it costs them more than that. There is nothing embarrassing about a bowel that isn't working correctly. There is only a body doing what bodies do, having problems that need attention, just as a heart or a kidney or a joint does. The same intelligence and willingness to seek help that you'd apply to any other symptom applies here. Your quality of life, your cognitive clarity, your comfort, your independence, all of these are affected by how your gut is functioning. That makes this a serious health topic, deserving serious attention, and it makes any conversation about it with a trusted physician not just acceptable, but essential. I want to hear from you in the comments, and I realize this is a more private topic than most, so share only what you're comfortable sharing. But do you recognize any of what I've described? The gradual normalization of infrequent bowel movements, the medications that were never paired with a bowel regimen, the secondary symptoms that seemed unrelated? What part of this conversation surprised you most? If you found this helpful, please share it with someone who might benefit, particularly a family member managing multiple medications, or someone whose bowel habits have changed since a surgery or a new prescription. Sometimes the information that helps most is the information nobody thought to offer. There's another video here about the connection between gut health and cardiovascular risk that I think you'll find genuinely interesting. It builds directly on today's conversation and takes it in a direction most people don't expect. Take care of yourself. Your gut is doing more for you than you realize. And it's worth listening to.